Hello again. This is Dr. Eric Kroll, family physician with MyDPC Doc Family Medicine. And thank you for your interest in today's discussion on screening for premature cardiovascular disease. This is a topic near and dear to my heart, both professionally and personally. One of my greatest passions is preventing that sudden, unexpected heart attack that seems to occur in people who were otherwise apparently healthy. And this is an important topic because there's a lot of misconceptions out there in the public about the risk for heart disease and the role that cholesterol and fat plays in heart disease. So I just want to take a moment to talk about what really leads to cardiovascular disease and how we can go about screening for that so individuals can be identified and treated before that event occurs. So there are many risk factors for heart disease. It is the number one cause of premature death. And one of the reasons why it's so difficult is that the risk factors for heart disease involve lifestyle to a great extent, which is hard to control. And again, getting back to what we've discussed previously, there's a tremendous sense in the medical community as well in the general public that cholesterol is a major player in the development of heart disease. So I'm not disputing the fact that cholesterol is important. Cholesterol is a big risk factor for heart disease, and it's one of the main ones. But it's not the cholesterol number as measured in the blood test that is the important factor. So knowing your cholesterol number is important, but not everybody who has high cholesterol needs to be treated with a medication. And we would like to be able to narrow our focus on who needs to be treated by only treating those people who actually have early signs of the disease or plaque formation. So let me expand a little further. We know that there are many people who have cholesterol levels of 300 and they never get heart disease. And we also know, unfortunately, that there are many people who have cholesterol levels throughout their life in the 150 to 180 range, and their risk of heart disease is underappreciated and they go undetected. And the reason for this disparity is because it's the cholesterol particle size and the amount of cholesterol that really matters. So if you have tiny, densely packaged cholesterol particles, you're more likely to build up plaque in your arteries and have heart disease. If you have a lot of cholesterol, but the particle sizes are big and fluffy, you're less likely to go on and get heart disease. So if we treat everybody who has high cholesterol, we are going to treat millions of people who actually are not at increased risk and expose them to the potential side effects of cholesterol medicine. If we rely too much on the numbers and we fail to adequately appreciate the risk of people with normal cholesterol, but it runs in their family, so they are harboring these tiny particles and plaque starts forming in their 30s and early 40s and it goes undetected. So interesting to note, but what can we do about it? Well, there are genetic tests that can be done. There's many labs that do them, and the prices for these blood tests are getting to be much more affordable in the range of about $100. So you can have a test to check not just your cholesterol amount, but the size of your cholesterol particles, the stickiness of your cholesterol particles. And so that blood test would tell if you are at greater risk than what we could appreciate with just a regular blood test. But realize, even though that is a fancier way of assessing risk, you're still just measuring risk factors. You're not actually looking for the disease itself. So there is a way, a non-invasive way, that you can be screened for the early presence of plaque in your arteries. And it's an ultrasound that's done on the carotid artery in the neck. It's called CIMT. And many of you may be familiar with carotid ultrasounds that are done for screening purposes through the LifeScan program, LifeScan screening. And that is a useful screen, but it's giving different information. The LifeScan screen, it measures how fast the blood is flowing in your carotid, and then there's a computer program which converts that to a percentage. So you really don't see that test being abnormal until there's already enough plaque in your arteries to narrow blood flow. And the same thing applies to stress tests. Many people are known to have a stress test and then not only to have a heart attack occur later. A stress test is only going to show blockage if the artery is blocked enough already that the blood flow is being limited. So all of the efforts that we currently make in most cases to diagnose heart disease are only diagnosing the condition when the horse is already out of the barn. And our goal from a prevention standpoint is to find out that someone is a plaque former way early in the disease process. So their specific genetic cholesterol abnormality can be treated before the plaque process continues. So most of the time, if these abnormalities exist, there's a clue based on family history. And I recommend that anyone who has a family history of early heart disease, where men in their 40s or 50s and women in their 50s and 60s have actually had heart attacks, strokes, stents in their arteries, that type of thing, that those families are more likely to have an abnormality that could be inherited. So relying on the cholesterol numbers in someone with that kind of family history is not a good idea. There should be a genetic cholesterol test done. And then anybody who's considering treatment for their cholesterol really should have a CIMT screening done so that they know whether there really is a great enough risk to go ahead and start treatment. And anyone who has the family history, even if their cholesterol testing looks good, it's certainly reasonable to do the CIMT screening. And in a former video, we talked about the issue of a ketogenic lifestyle being an actual healthy way to live and the reasons why that does not predispose to plaque buildup. And I am an advocate of that type of a lifestyle, and I think it's very helpful if you're going to consume a diet that's 75% fat, that it's nice to monitor what's going on with the fats in your bloodstream, through one of these advanced cholesterol tests to see what effect the diet is having on your particle sizes and the amount of cholesterol. But again, most importantly, knowing whether you're really at risk for heart disease, whether you're a plaque former, by checking a CIMT screening, and then at regular intervals in the future, say 2 years, 3 years down the road, perhaps after following a ketogenic lifestyle, you can get the reassurance that this way of living is not predisposing you to cardiovascular disease, because you can see what's going on within the layers of your artery wall. So I hope you find this information helpful and useful. If you have questions about whether you are at increased risk enough that you should have some advanced cholesterol testing, or whether you should be screened with a CIMT of the carotids, feel free to send me an email, drcrawl@mydpcdoc.com. I'd be happy to individually discuss your risk with you. And if you're interested in having the CIMT screening, I do those periodically in my office, and that can easily be done. So thank you again for your interest, and you have my best regards for ongoing good health and healthy longevity. And remember, if you're trying to achieve healthy longevity, that not enough time is a euphemism for not enough desire. Thank you again.